Ma'am, now we are live. So with your permission, can we start, ma'am?
Yes, we can start.
Okay, so good evening, everyone. Good evening, doctors and participants. Today we are having a webinar with the topic Gestational Diabetes Mellitus and its Management. So for today, our guest speaker, our Dr. B. Rajakumari ma'am. She is a very senior doctor and she is having a lot of experience. Ma'am done MBBS, DGO and DNB. Ma'am done MBBS in 1990 from Siddhartha Medical College. Then ma'am done DGO in 1993 from Andhra Medical College. Then ma'am done DNB in 1995 from Andhra Medical College. And apart from that, ma'am also done some specialist training courses like laparoscopic training at Chennai and Bombay. And also ma'am done one more training, that is infertility training at Bangalore. And ma'am currently she is director at Rajakumari multi-specialty hospital, and ma'am currently vice president Foxy for Kakinada. So with this small introduction, ma'am, I'm handovering the session to you. So you can please take, ma'am, the slides.
Thank you for your nice introduction. And dear colleagues, thank you for participating in this webinar. And today's topic is gestational diabetes mellitus. And I am telling thanks to Shield Connect people for giving me this opportunity. Gestational diabetes mellitus is defined as carbohydrate intolerance with onset or recognition during pregnancy. We will discuss about the pathophysiology of GDM. We are all well aware of the pathophysiology. I will discuss in brief. There are a lot of physiological adaptations will occur during pregnancy to maintain the euglycemic state. In early pregnancy, insulin sensitivity increases, promoting glucose uptake into adipose tissues in preparation for the energy demands of later pregnancy. In pregnancies where the normal adaptations fail to occur adequately, result in GDM. It is usually the result of beta cell dysfunction and insulin resistance. Beta cell dysfunction may be the result of prolonged and excessive insulin production in response to chronic fuel excess. It may be noted that majority of susceptibility genes that are associated with GDM are related to beta cell function. Even a minor deficiency in the beta cell machinery may get exposed in times of metabolic stress of pregnancy. Whereas insulin resistance develops due to various factors, of which major importance is the placental hormones. As the placenta grows in size, placental hormones also increase in quantity around from 24 to 28 weeks of gestation. That's why GDM occurs most commonly in the second trimester of pregnancy. And instead of insulin resistance in pregnancy is 3 times more than normal women. Other factors contributing to insulin resistance are diet, high protein diet, which is determinantal, and failure of insulin signaling and neurohormonal dysfunction. It is due to the release of from adipose tissue, the cytokine will be more during pregnancy, and these impair insulin signaling and inhibit insulin release from beta cells. And changes in the gut microbiome is the major contributing factor, and which causes the increase in gut permeability to cytokines, and which causes insulin resistance. And oxidative stress is also another contributing factor. And when these compensatory mechanisms fail, it causes TDM. The prevalence in India is higher when compared to European countries. It is more than 11%. In all over India, it is around 27.6%. It is an iceberg phenomenon because most of the cases are undetected because of lack of tests. And in different areas, the prevalence is different depending on the ethnic group. In the rural areas, from 9.9% to in urban areas, around 17.8%. GDM is defined as carbohydrate intolerance resulting in hyperglycemia of variable severity which is detected after first trimester of pregnancy and not related to the overt diabetes. And it cannot exclude the possibility of glucose intolerance developing concomitantly with pregnancy. And according to FIGO, recommends the term hypoglycemia in pregnancy. What are the complications of mother and offspring in GDM? We all well aware of all these complications. Like in pregnancy, preeclampsia is more. Maybe because of the risk factors are same for both the conditions. And in the labor, there is increased induction of labor, cesarean sections, and operative deliveries and labor complications, all this due to macrosomia. And during postpartum and beyond, we have to discuss in detail about recurrent GDM and type 2 diabetes later. In offsprings, congenitally, there may be anomalies in CNS and cardiac, but there is altered fetal programming causing increased large per gestational age and macrosomia, increased fat mass. There are neonatal complications like prematurity, perinatal asphyxia, respiratory distress. All these are related to delayed lung maturity. And metabolic complications like hypoglycemia and hypocalcemia, polycythemia, hyperviscosity, and hyperbilirubinemia, cardiomyopathies. And in long-term outcome causes, obesity, type 1, type 2 diabetes, or metabolic syndromes in the children. How to identify GDM? The diagnostic test for GDM is OGTT. As we all know about the OGTT, I need not tell in detail. We should do it at first antenatal visit and at 24 to 28 weeks of gestation. GDM is diagnosed if 1, 2, or more glucose levels are equal or exceeded. According to American College of Obstetrics and Gynecologists and NICE, recommends that women who have had previous pregnancy GDM should be offered diagnostic testing, and in obese women and women with impaired glucose metabolism as early as possible to identify undiagnosed type 2 diabetes. According to Australian Society, they recommend a risk factor assessment in early pregnancy, and OGTT is offered when there is 1 high risk factor or 2 moderate risk factors. The risk factors for GDM are personal characteristics like ethnic group with a high prevalence of type 2 diabetes, maternal age more than 25 years, BMI more than 30 kg per square meter, and whereas medical disorders like metabolic syndrome, PCOD, and hypertension, and family history or genetic factors, and diabetes in first degree relatives, and past pregnancy factors like GDM, unexplained perinatal loss, poor obstetric performance, birth of malformed infant, and macrosomic baby. In present pregnancy factors, we have to see when there is a glycosuria at the first antenatal visit in first trimester, or excessive weight gain in the first 24 weeks, in multiple gestation, repeated urinary tract infections, and candidiasis, repeated candidiasis infections, we have to suspect. In epigenetic factors are like unhealthy food habits and overeating and lack of regular exercise, HDL less than 35 milligrams per deciliter, triglycerides more than 250 milligrams per deciliter. What are the guidelines for screening for GDM in India? Universal screening at first booking. That is fasting plasma glucose when it is fasting less than 92 milligrams per deciliter, it is non-GDM. Then we have to do single step OGTT at 24 to 28 weeks. When the fasting levels are 90 to 125 milligrams per deciliter, then it is GDM. If fasting is more than 126 or HbA1c more than 6.5%, it is overt diabetes. When the OGTT test done at 24 to 28 weeks, we have to consider according to International Society, the following values. Fasting 92, 1 hour 180, 2 hours 153 milligrams per deciliter. If all values are normal, it is non-GDM. In high-risk cases, we have to repeat GTT again at 32 weeks. If any one abnormal value, consider it as GDM. Current and previous criteria recommended to diagnose GDM are, briefly we will discuss. In 75 grams OGTT, according to International Society, fasting is more than 5.1 and 1 hour post-load more than 10, 2 hours post-load more than 8.5 millimoles per liter. In 100 grams OGTT, SCOG, according to SCOG, more than 5.3, fasting in 1 hour post-load is more than 10 millimoles per liter, 2 hours post-load is more than 8.6. What are the protocols for investigations? Testing is the most important in GDM. It is during first antenatal contact as early as possible in pregnancy. And if it is negative, then it should be repeated again at 24 to 28 weeks of pregnancy. Irrespective of gestational age, at what time they come, we have to do OGTT test immediately. Pregnant women testing for GDM at first antenatal visit is giving 75 grams of oral glucose and measuring blood sugar levels after 2 hours. If the value is more than 140 milligrams per deciliter, it is positive, managed as GDM. If it is negative, less than 140 milligrams per deciliter, repeat testing at 24 to 28 weeks. If it is positive, more than 140 milligrams per deciliter, managed as GDM as per guidelines. If it is negative, that is less than 140, managed as normal antenatal case. According to Dixie, it is a universal screening, which is a simple, feasible, acceptable single-step procedure. Sheshaya et al. Recommended is a single-step procedure irrespective of the last meal. Pregnant women attending antenatal OPD were given 75 grams anhydrous glucose into 50 to 300 ml of water, which should be consumed within 10 minutes. And plasma glucose was estimated after 2 hours. The rationale for non-fasting status is when euglycemic patient, that is normal pregnant woman with euglycemic state, even though glucose challenge was given, there won't be any increase. Whereas in GDM case, there will be increase in sugar levels with glucose challenge due to impaired insulin secretion. In 2 hours, it is more than 200 means it is diabetes mellitus. If it is more than 140, it is GDM. If it is more than 120, it is decreased gestational glucose tolerance. National guidelines by Ministry of Health and Family Welfare India. Pregnant women in community, they should be tested for GDM at first antenatal visit, and it is positive to more than 140, then managed as GDM. If it is negative, repeat test at 24 to 28 weeks. Positive means managed as GDM, negative means managed as normal antenatal case. Management of GDM. The objectives of the management will be to ensure optimal glycemic control during pregnancy and labor and prevent fetal and maternal complications. All pregnant women who test positive for GDM for the first time should be started on medical nutrition therapy and physical exercise for 2 weeks. The exercise should be for 30 minutes a day, 5 days a week. After 2 weeks of intermittent physical exercise, 2 hours PPBS should be done. If the PPBS is less than 120, repeat test every month during second and third trimester. More follow-up tests can be done as recommended by the treating physician. If it is more than 120, medical management to be started as per guidelines. What is medical nutrition therapy? The principles of medical nutrition therapy is The objective is, in addition to maintaining a normoglycemic state, will be able to provide balanced diet so that adequate nutritional requirements of both mother and fetus are addressed. The goals is to achieve normoglycemia and prevent ketosis and ketonemia, which impair the physical and mental development in offspring, and to maintain proper weight gain, that is around 10 to 12 kgs. An addition of 350 kilocalories per day above the adult requirement is recommended during second and third trimester. And so as the maternal and fetal well-being will be good. The diet should be balanced as follows. Carbohydrates around 50 to 60% and protein around 20 to 25% and fat is 25%. Less than 10% should be saturated fats. Hypocaloric diets are adversely impair fetal growth. So balanced diet is a must. That balanced diet is calculated depending on the energy requirements based on the BMI. Metformin or insulin should be started once GDM is not controlled on MNT. And however, insulin is the drug of first choice. If the woman's blood sugar is not controlled with the maximum dose of metformin and MNT, insulin is to be added. Hypoglycemia and weight gain with metformin are less in comparison to insulin. The common side effects that occur with metformin include diarrhea, nausea, stomach pain, heartburn, gastritis, and serious side effects are lactic acidosis and low blood sugar. The dose of metformin is 500 mg will be started initially, then later increased depending on the glucose levels. In the initial days, when the metformin studies are not well established, we used to give insulin as the first drug of choice. Nowadays, we are using metformin. Regarding insulin therapy, we can use actropid or mixitod. In a simplified form, dose requirement is calculated like this. First trimester 0.7 unit per kg, in second trimester 0.8 unit per kg, in third trimester 0.9 unit per kg, a term 1 unit per kg. It is start with 4 units 3 times daily, then titrate according to the glucose requirement. 1 unit insulin reduces blood sugar level by approximately 30 to 50 milligrams per deciliter. When mixitod insulin used, 2/3 of the dose should be given in the morning with breakfast, 1/3 of the dose should be given at night time with dinner. Usually before advising insulin, opinion from endocrinologist is obtained. Insulin therapy. Pregnant women with GDM, medical nutrition therapy for 2 weeks. If 2 hours ppbs is more than 120, then start mixitod. Subcutaneous injection 30 minutes before breakfast once a day. Dose of insulin is calculated by blood sugar levels, like if the blood sugar is between 120 to 160, 4 units. If it is 160 to 200, it is 6 units. More than 200 means 8 units. And then fasting blood sugar and 2 hours postprandial blood sugars every third day. If the FBS is less than 95 and ppbs less than 120, continue same dose, MNT and physical exercise. If the FBS is less than 95, ppbs more than 120, increase the dose of insulin by 2 units pre-breakfast, plus MNT and physical exercise. If the FBS more than 95 and ppbs more than 120, give injection insulin pre-breakfast and pre-dinner also. And repeat FBS and ppbs every third day till the dose of insulin adjusted. If the FBS is more, then we have to increase the dinner dose. If the ppbs is more, we have to increase the pre-breakfast dose. After adjusting the dose, continue same dose of insulin and MNT and physical exercise in all cases. Hypoglycemia. It is the most common complaint in GDM patients when they are insulin. It is diagnosed when blood sugar level is less than 70 milligrams per deciliter. The patient feels the following complaints, and there is hypoglycemia, like hunger, easy fatigability, headache, sweating, palpitations, tingling sensation. And in a severe hypoglycemia, they may go into mental confusion, abnormal behavior, visual disturbances, nervousness, or anxiety. The uncommon complaints are seizures and loss of consciousness. Hypoglycemia should be treated promptly by giving glucose immediately. If glucose is not available, they can take sugar or any fruit juice or anything which is a sweet, and they must take rest and avoid any physical activity. And they can take any food available. And if hypoglycemia continues, repeat same amount of glucose and wait. If pregnant woman develops more than one episode of hypoglycemia, they should consult a doctor immediately. If diagnosed before 20 weeks of pregnancy, the first trimester anomaly scan, dual markers, and fetal anatomical survey by USG should be performed at 18 to 22 weeks. For all pregnancies with GDM, growth scans can be done at 28 to 30 weeks and at 34 to 36 weeks. At least 3 weeks gap between two ultrasounds. It should include fetal biometry and placental morphology localization and amniotic fluid estimation. Fetal surveillance in pregnant women, because the fetal neonatal deaths, fetal death in utero, and stillbirths are more common. We have to take care about the fetal surveillance. And we educate the patient about the daily fetal moment count. That is, we have to ask her to count after breakfast 1 hour, after lunch 1 hour, after dinner 1 hour, to count fetal moments and write down on a paper every day. If there is any decrease in fetal moments, she can notice and she can come immediately for checkup. It should be started from 32 weeks onwards. And during labor and timing of delivery, what precautions we should take? In a pregnant woman with well-controlled GDM has not already delivered spontaneously, induction of labor can be scheduled at or after 39 weeks of gestation. Because GDMs are associated with delay in lung maturity, routine delivery prior to 39 weeks is not recommended in well-controlled GDM. Whereas in uncontrolled GDM, when there are associated risk factors like hypertensive disorders, previous stillbirths, other complications, they should be delivered earlier. Vaginal delivery should be preferred, and LSCS is limited only for obstetric indications. When there is fetal macrosomia, elective section can be done to avoid shoulder distortion. What precautions we have to take during labor? Pregnant women with GDM on medical management require blood sugar monitoring every 2 hours, and the morning dose of insulin or metformin is withheld, and IV infusion with normal saline to be started, and regular insulin to be added according to the blood sugar levels. That is, if it is around 90 to 120 milligrams, we need not add insulin. If it is 120 to 140, 4 units. 140 to 180, 6 units. If it is more than 180, 8 units to be added. All neonates should receive immediate essential newborn care with emphasis on early breastfeeding to prevent hypoglycemia. Post-delivery follow-up of pregnant women with GDM. Immediate postpartum care with GDM is not different without GDM. Maternal glucose levels usually return to normal after delivery. Even though glucose abnormalities, the carbohydrate metabolism abnormalities occurred in pregnancy, to come to normal level, it will take 3 to 6 months. The glucose levels become normal immediately after delivery. There is no need of insulin or metformin after delivery if the glucose levels are normal. Then we have to do 75 grams OGTT at 6 weeks postpartum to evaluate the glycemic status of woman. They should be counseled for healthy lifestyle and behavior, particularly role of diet and exercise, because to prevent recurrent GDM and type 2 diabetes mellitus. Antepartum care. In a community, we have to give awareness regarding GDM, and we have to mobilize the patients for getting them the OGTT test. And it can be done at antenatal clinics. And data regarding on negative test, we have to counsel the patient about the second test, counseling for GDM. If it is positive, we have to counsel them regarding MNT and lifestyle changes. And monthly follow-up. And if the glucose levels are not come to euglycemic state, if it is more than 120, we have to give them metformin or insulin, and we have to train them, self-injection training. And glucose monitoring also, we have to educate them. And they have to record blood sugar levels and when they come to follow-ups. And refer to higher facility in case of danger signs or uncontrolled blood sugar. Intrapartum care regarding GDM positive women for delivery. GDM positive women on MNT with controlled blood sugar can be managed as any other normal labor. In GDM positive women on insulin or metformin with controlled blood sugar, withhold morning dose of insulin or metformin, start infusion of insulin in normal saline, monitor for complications and data recording. GDM positive women with uncontrolled blood sugar, refer to higher center. What is the immediate postpartum care we have to give? Regarding mother, we have to counsel her for postpartum family planning and counsel the woman for 6 weeks postpartum follow-up test. Detailed examination of women before discharge. In newborn, initiate early breastfeeding. Blood sugar monitoring of newborn of GDM positive women within the first hour of birth and repeated 4 hours after 4 normal feedings. The management of newborn hypoglycemia is very important because it causes effects on CNS and CVS. And long-term complications like seizures and mental retardation and developmental delays may also occur. Who should be screened early? According to ACOG guidelines, consider early screening in pregnancy if the patient is overweight with a BMI of 25, when there is physical inactivity and impaired glucose metabolism, and there is previous pregnancy history of GDM, macrosomia, and stillbirth, hypertension, and when there is HDL cholesterol low and fasting triglycerides are more, and in PCOS and acanthosis nigrans, non-alcoholic state hepatitis, morbid obesity, and other conditions associated with insulin resistance, and the HbA1c is more than 5.7%, and impaired glucose tolerance, and cardiovascular diseases, and family history of diabetes. These all cases should be screened early. And regarding diet, this is most important part, the nutritional assessment and plan. A food chart should be prepared in consultation with the dietitian to suit the likes and tastes of the woman. Recommended complex carbohydrates, that is 3 meals and 2 snacks to limit glucose fluctuations. And according to BMI, we have to calculate energy requirements. That is when the BMI is low, that is less than 18.5, up to 40 kilocalories per kg can be given. When it is normal, 18.5 to 22.9, energy requirement is around 30 kilocalories per kg. When overweight, 23 to 28.9, 22 to 25 kilocalories. when is more than 28.9 up to less than 15 kilocalories per kg body weight. And the meals is around 6 a.m. We have to advise them egg white and milk. And around 8 a.m. we advise them breakfast, 2 idlis. If it is dosa, 1, pesret, it is 1. And around 10 a.m. we will advise them to take some ragi gruel or oats with the dry fruits. And around 12 to 1 p.m. we advise them to take meals with 100 grams of carbohydrate diet and with 100 grams of curries, which are prepared with only 5 to 10 ml of oil. And around 4 p.m. we advise them to take snacks like sprouts or brown nuts and protein diet. And at evening 6 p.m. they can take milk. And in the night they can take 2 or 3 chapatis with curries and only 50 grams of rice. And around bedtime they can take oats also. We should distribute the calories. We shouldn't dump the at a time. We have to advise them to take meals in around a gap of 4 hours like that. 30 minutes of moderate intensity aerobic exercises at least 5 days a week or minimum 150 minutes per week. If they can't walk at a stretch, we can advise them to walk every hour 10 minutes. Monitor glucose levels after beginning dietary recommendations to confirm glycemic control. Pharmacological treatment. ACOG recommends insulin is the preferred therapy if glycemic control is not obtained with non-pharmacological treatment. The starting insulin dose is 0.7 to 1 unit per kg daily. Dosage should be divided into long-acting and intermediate-acting. Usually, we will give Actrapid in the before breakfast and before lunch, and mix it out at night time to maintain the adequate glycemic control. Pharmacological treatment. If the patient can't take insulin or declines, metformin can be used. We have to counsel about metformin risks, including placental crossover and no long-term studies in offspring available. Previously, we used to give only insulin, not metformin, because of lack of studies. But nowadays, after a lot of studies are there, now we are prescribing metformin as the first choice. If it is not controlled with metformin, then we are adding insulin also. The starting dose of insulin is 500 mg. For 1 week, increase to 500 mg twice daily. Check baseline creatinine and LFT. The adverse effects will be abdominal pain and diarrhea. Glyburide, it is not used in pregnancy. We are not at all using because it shows worse outcome, including macrosomia and birth injury. Fetal monitoring, according to ACOG guidelines. On medication with poor control and without comorbidities, the fetal monitoring should be started at 32 weeks. At each antenatal visit, we have to do NST test. Begin earlier if other comorbidities are present. Well controlled on diet. No consciousness due to lack of data demonstrating stillbirth risk. Fetal assessment may not be necessary, but according to the patient requirement and any risk factors, we have to do the plan accordingly. Fetal assessment. When to deliver. Controlled on diet, expectant management up to 40 weeks, 6 days is appropriate with antepartum testing. Without antepartum testing, we have to plan at around 39 weeks. To 39 weeks, 6 days. When poorly controlled, expert guidance supports early delivery. Delivery between 37 weeks to 38 weeks, 6 days is justified. Delivery between 34 weeks and 36 weeks to 6 days is reserved for failure in hospital glycemic control and abnormal fetal testing. And there is macrosomia, counsel regarding the risks and benefits of a scheduled cesarean section should be given. Nice guidelines regarding continuous glucose monitoring. There are a lot of studies are there on this continuous glucose monitoring. They found that glucose control targets are achieving, they are achieving glucose control effectively, and there are fewer cesarean section, fewer neonatal intensive care admissions. CGM was associated with better clinical outcomes. NICE guidelines regarding eligibility criteria for the NHS Diabetes Prevention Program has been expanded to all women with a history of previous gestational diabetes, including those with normoglycemia. Women with the previous GDM are classed as clinically extremely vulnerable and advised to have HbA1c as soon as feasible and unless performed within the past 12 months. Nationwide implementation of postnatal HbA1c measurement at 3 to 6 months in conjunction with infant vaccination. Instead of this fasting plasma glucose at 6 to 12 weeks. It improves postnatal GDM care. NICE research recommendations for quality research focused on exploring the barriers to achieving pregnancy glucose targets are to examine the effectiveness and accessibility of insulin pump therapy and CGM use in women with diabetes who are planning pregnancy. To establish a barrier testing, diagnosis, and intervention for the gestational diabetes improves maternal, fetal, neonatal outcomes, including fetal hyperinsulinemia. To explore the barriers to achieving pregnancy glucose targets in women with gestational and pre-gestational diabetes. To determine the most clinically and cost-effective approaches for identifying fetuses most at risk of death. To investigate what pharmacological interventions may delay or prevent type 2 diabetes developing in women with gestational diabetes. The maternal glucose levels are the key modifiable predictor of the perinatal death. CGM is considered in a severe hypoglycemia, which is not controlled, unstable blood glucose level that are causing concern despite efforts to optimize glycemic control. In them, CGM is preferred. It is suitable for pregnant women with type 2 diabetes. Gestational diabetes criteria as per American Diabetic Association standards, that screening is at first antenatal visit, screen for undiagnosed type 2. In those with risk factors, or at 24 to 28 weeks of gestation for all pregnant women not known to have diabetes. Screen women with diabetes mellitus for diabetes at 6 to 12 weeks postpartum. And test is to be done as one step 75 grams OGTT fasting and at 1 and 2 hours. And a 2-step NIH, 50 grams glucose load and a plasma blood glucose test after. If it is more than 130 to 140, then go to step 2. The diagnostic criteria are in 1 step 75 grams OGTT test, if fasting is more than 92, 1 hour is more than 180, 2 hours is more than 153. 2-step step 2 procedure, at least 2 or 4 plasma blood glucose measure after OGTT are met or exceeded. Metformin in PCOS women for preventing GDM. There are a lot of studies, but there is no strong recommendation, no strong evidence that it has preventive effect on GDM. Whereas metformin, while using in PCOS patient when they became pregnant, we can continue metformin in first trimester to prevent first trimester losses. The goals of therapy may be achieved by controlling calorie intake tailored to maternal and neonatal needs so that mother gain proper weight during pregnancy, and by avoiding long fasting. It is recommended to receive 20% calorie intake from proteins, 50% from carbohydrate, 30% from fat with the proper distribution. Glucocorticoids, is it safe in using pregnancy? when we are planning preterm delivery, it is a must. We can give glucocorticoids without any hesitation. While administering glucocorticoids, we have to admit the patient to monitor the blood glucose levels, as the blood glucose levels will be increased. So as to adjust insulin dose, we have to admit them. In women with a GDM with a acceptable glycemic control without insulin therapy, warning about the risk of hyperglycemia and closure monitoring is advisable. And blood sugar should be tested after 6 hours of steroid administration for dose adjustment of insulin. GDM in the pandemic. In the evolving pandemic, in order to minimize the viral exposure of women and minimizing the health service burden, whereas balancing GDM detection, there are tests advised like this. HbA1c and random plasma glucose are advised at the first antenatal visit. And avoid OGTT at 24 to 28 weeks. Instead, offer HbA1c along with fasting plasma glucose. Identify and monitor women with past GDM. Apply a personalized risk calculator and monitor for any complications of GDM listed in routine care. Real-time evaluation of impact of pandemic screening strategy. When the first antenatal visit, and around 8 to 14 weeks gestation, if HbA1c is more than 6 and random plasma glucose is more than 200, it is overt diabetes. And the HbA1c is 5.9 to 6.4%, RBC 160 to 200 milligrams per deciliter, it is early GDM. And the HbA1c is less than 4.1 and 5.9%, then we have to recheck at 28 weeks gestation. If the values are more than 5.57% and fasting more than 100, random blood sugar more than 162, then we will consider it as GDM. If the HbA1c is less than 5.7% and fasting plasma glucose less than 100, RBS less than 162, then it is no GDM. How to manage GDM? In a hospital with the remote consultation and giving education to patient on GDM and capillary blood glucose monitoring, and inform community midwife about the care of the woman, and ultrasound soon after diagnosis of GDM and obstetric appointment. 1 week later, remote review of blood glucose control by diabetes team. If it is normal, well controlled, no comorbidity, it is low risk. We can continue remote diabetic review and continue antenatal checks in community. Remote obstetric review at 36 weeks and planned delivery. If CBGs are not well controlled, remote consultation with the diabetes team on pharmacological treatment or comorbidity, it comes under high risk cases. Then we have to continue diabetic review and face-to-face reviews with the diabetologists and obstetric appointments and ultrasound for growth as per local guidelines and obstetric reviews, and face-to-face obstetric review at 36 weeks and to planned delivery. Role of myo-inositol in GDM treatment. Based on current evidence, myo-inositol supplementation reduces the risk of GDM among obese and overweight pregnant women, as well as women with PCOS or a family history of type 2 diabetes mellitus. There are a lot of clinical studies gone on the myo-inositol. 2 grams oral myo-inositol when started soon after the diagnosis of GDM as adjunct to dietary modification is effective in achieving glycemic control. Thus, it is decreasing the need for pharmacological therapy. In clinical practice, I found myo-inositol is working well because it is due to insulin mimetic qualities like blood flow translocation to the plasma membrane, then leads to increase of glucose transport through blood flow into cells. Myo-inositol not only improves insulin resistance, and it also increases the action of endogenous insulin. So in practice, in high-risk cases and in patients who are obese and who are prone for GDM, as a preventive aspect, I am using myo-inositol and MNT, and I'm advising exercise regularly for this patient, even though they are not detected as GDM, to prevent GDM. Combination of myo-inositol and alpha-lactalbumin may reduce insulin resistance and excessive fetal growth in women with GDM. Furthermore, a reduced rate of insulin treatment and preterm birth was demonstrated in the treated group. Take-home message. GDM is an iceberg phenomena which can be detected by improving community awareness and universal screening of all pregnant patients. In high-risk cases, patients with past history of GDM can be started on myo-inositol, MNT, and exercises so as to prevent progression to GDM. If GDM is not controlled with MNT and exercises, then metformin or insulin can be started under the guidance of endocrinologist. GDM is also associated with significant risk for the fetus. Fetal surveillance is very important to prevent intrauterine and neonatal complications. Daily fetal movement count is a must. Pregnant women with a GDM should deliver at health facilities only. Postpartum care is important to prevent type 2 diabetes mellitus. Hello. Dear doctors, can anyone share your experiences with GDM?
Ma'am, doctors are joined on delegates link, ma'am. So they can hear us, but they cannot share here, ma'am.
Okay.
So we can take their questions, ma'am.
In the end, I would like to add few tips regarding management of GDM.
Okay, ma'am.
As we all well versed with the GDM, I want to give tips to the upcoming doctors. Like we have to maintain euglycemic levels strictly, and universal screening is a must. And depending on the patient's conditions, risk factors are there. We have to, even though 24, 28 weeks, even if it comes normal, we have to do tests repeatedly every 15 days or every month, depending on the patient condition. And we have to advise patient accordingly these medical nutrition therapy and exercises and proper diet plan also we should give them. And regarding myo-inositol also, it's useful.
Thank you, ma'am, for sharing your feedbacks, ma'am. So, ma'am, I will see, ma'am, if any questions we have, ma'am, from our delegates or the doctors, those who joined, ma'am. Just give me a few seconds, ma'am. I'll just go through and check, ma'am. So, ma'am, the first question is, ma'am, am I audible, ma'am?
Yes, audible.
So, ma'am, the first question is, what is the first preference as a nutritional when any pregnant woman diagnosed with GDM? What is the first preference, ma'am, as a nutritionals, ma'am?
What it means, I already told about the diet plan.
Yes, ma'am. Okay.
And that is low carbohydrate diet we will prescribe. Low carbohydrate and low fat diet. And avoid these foods with unsaturated fatty acids like cookies, ice creams, and those palm oil and vanaspati oils and unhealthy oils, they should avoid.
Okay, thank you, ma'am. Ma'am, one more question is there, ma'am. Ma'am, is there any relationship between iron deficiency and GDM?
There is no relationship I found.
Okay,
because of this obese people only, I found this GDM is interesting.
Okay, ma'am. So, ma'am, okay. And now this is with, we have pandemic. So related to that, one question we have. So are pregnant women with GDM issues at risk of COVID-19 infection, ma'am?
Yes, because of less immunity, because of neutrophils, and that function will be less.
Okay.
Because of all the cells are loaded with glucose, the cells won't function properly. Because of less immunity, they are prone to more infections.
Okay, ma'am. So I can see one more question, ma'am. So the last question, ma'am, what are the preventive steps, ma'am? Like, may I know the apart from this nutritional or the diet you are advising, ma'am? What are the other ways for preventing
Preventing before
or
conception
any
itself.
repeat second time pregnancy?
Before pregnancy itself, we have to counsel the patient to lose weight if they are obese, to maintain normal BMI, so that the GDM risk will be less. And take healthy diet. We have to advise them, take healthy diet and maintain normal weight.
Okay.
And we have to assess minimal blood tests and what are the deficiencies are there. We have to correct, like vitamin D deficiency. If there is any associated thyroid is there, that risk will be more.
Okay.
The thyroid dysfunction should be corrected.
Okay, ma'am. So, ma'am, one more,
Vitamin D deficiency should be corrected.
Vitamin D deficiency. Okay, ma'am. Ma'am, one more question I can see here. Like, ma'am, when for any pregnant woman, we are giving or you are suggesting prescribe folic acid. So what are the other nutritionals along with folic acid you are giving, ma'am? And what is folic acid till what duration you are giving, ma'am, to the patients?
Along with folic acid, we will advise vitamin C.
Okay, ma'am.
And multivitamins, iron tablets, and calcium. And folic acid is advised up to the 20 weeks of gestation. And after that, if the iron along with iron, folic acid will be there. We need not prescribe separately folic acid.
Okay. Okay. Thank you so much, ma'am, for having your time and sharing your own feedback for the upcoming doctors. I hope this all information is very useful, and these questions also you given a good response, ma'am, so that all our participants, those who join, they can all get benefited with this, ma'am. So, ma'am, once again, thank you so much, ma'am, for joining with us and conducting your first webinar with us with Shield Connect, ma'am. We are hoping for many more webinars from your end, ma'am, on multiple topics. And thank you, ma'am.
Thank you very much.
Thank you so much. Have a good day, ma'am.
Thank you.
Madam Garu, thank you very much, Madam Garu.
Thank you.
Thanks, ma'am.
So, ma'am, can we close the webinar, ma'am?
Okay. Okay.